Hi, everybody. Welcome to SimiTree's webinar. We're really glad you guys are here today. We'll get started here in just another minute. We're still waiting for people to log in. So as we're waiting for people to get logged in, I'll just go over a little bit of the basics. If you have questions today during the webinar, please don't hesitate to use the Q&A. Down at the bottom, you can put your questions right in there, and then at the end of the presentation, if we have time, we'll get back to them. If we run out of time, we'll be sure to email you out the answers. At any point in time, you can use the chat if you're running into any technical issues or if you have any questions. If you need anything at all, though, we're here to help you. So now we're at the top of the hour, so I think we're ready to get started. I want to welcome you all to SimiTree's webinar. I'm Missy Gilliland, the Learning and Development Manager here at SimiTree. Today we're going to talk about Medicare Advantage, and we have Lynn and Rob here to help get us started. So I'm going to hand it over to Lynn to introduce herself.
Thank you so much, Missy. Welcome, everyone. I'm excited to be here with you all. My name is Lynn Labarta, and I'm the Vice President of Lower Market RCM here at SimiTree. Again, super excited to do this webinar with you all, and I'll hand it over to Rob to introduce himself.
Thanks, Lynn, and thank you, Missy. And we're excited to be here to talk to you. Wednesday, it's midday. East Coast, early morning for those on the West Coast. So good morning, good afternoon, or happy hump day, however we want to go about it. It is the 1 year anniversary. I always remember this day. It's my wife's birthday, and it's the 1 year anniversary of SimiTree. So easy date to remember in my mind on that. So I'm Rob Simione. I'm a principal at SimiTree. I have been in Home Health and Hospice going on my 14th year. My role at SimiTree is I, along with Nick Seabrook and Aaron Masterson, oversee our consulting team. And I have sat in many of your shoes. I've been an interim CFO for many agencies, small, large, for-profit, non-for-profit, system-based, freestanding, part of a chain, all those different things. I've sat in your role. So I know this is a topic that probably a lot of you are interested in, and I'm always interested in this because I think this is one of the bigger challenges that a lot of agencies have, from the starting point of going through the process of getting Medicare Advantage contracts to going down and billing and making sure you're successful and making sure you're collecting the cash on it as well. So I'm excited to talk to you today about this, and I think it's a very timely topic, as you'll see in some of the information and the data we share. So, briefly, our agenda for this would be, we're looking over the current state Medicare Advantage. So we'll look at the growth and kind of what the volume's been looking like in terms of the numbers. Medicare Advantage contracting, we'll go through the revenue cycle process, some of the things to look for, tips and tricks, best practices that we see that work to make sure we're billing claims both timely as well, making sure we're billing them accurately to get paid as soon as possible. And then looking at the EMR, obviously, making sure you set up these contracts correctly in the EMR, which is really critical, making sure that you're able to execute and receive those payments. Because as I always say, nothing more frustrating than not receiving payment in a timely manner, especially when you're providing those services. I always give the example, right, is if you think even Medicare, right, Medicare typically doesn't pay you for 14 days after you submit a claim. Later you are with the claim, later is with payments. Medicare Advantage, I'm sure Lynn can tell you, it's even worse. You're not getting it 14 days after you submit the claim on that. So again, making sure you're effective and efficient there is so important, because we're in a staffing crisis where we're having to making sure we're paying our staff timely, meeting payroll, and doing all those things. And we want to incentivize our team to be able to, for the good work they're doing. And if we're not getting the cash, it creates obviously issues. So first, we're going to talk a little bit about the growth of Medicare Advantage, which I find kind of exciting, because I remember in the beginning when I started in this industry, Medicare Advantage made only probably about 5 to 10% of payments. It wasn't a huge amount on that. I mean, more majority of our business was, we were 60 to 70% Medicare. We've seen that change and flip pretty dramatically. In many states, traditional Medicare only represents maybe 50, to 60% of our business now. And Medicare Advantage, has been growing. Just some stats that we kind of looked at, specifically looking at some of the 2021 data, is there about an increase about 1.9 million beneficiaries in 2021. There's an 8% increase in Medicare Advantage beneficiaries. Congressional Budget Office projects 51% by 2030. So huge increase of what the beneficiaries of those enrolled in Medicare, that 51% of them will be enrolled in Medicare Advantage. 26 million total enrollees. Medicare beneficiaries reported 98% satisfaction with their benefit package in 2020. So again, from a patient's perspective, more people are going to enroll because they're more and more satisfied with what they're getting out of their Medicare Advantage program. We're also seeing the expansion of it in many states and through different service lines and programs, and we'll talk about that a little bit later. An average annual consumer savings of $1,640. Again, the program is providing savings, it's showing savings. Again, just opportunities there that we're going to see the continued trajectory of growth away from the traditional Medicare and more towards the Medicare Advantage payment models. So Medicare Advantage enrollment, just some additional information. As you can see, the projections, really has increased in terms of the enrollment. As 2015 was about 32%. In 2020, we're about 41%, and projecting about 51%. So you're talking about a 20% over the last, over 15 years, a 20% growth projection in Medicare Advantage enrollment. And again, this is going to become very, very significant for your agencies because it comes down to looking at the contracts, negotiating the contracts, looking at the payment models, how they're set up appropriately, how you're going to bill for those, which we'll talk about today. So it's a growing part of your business that you definitely don't want to ignore. The other thing I find fascinating too is just looking at some of the data. Is look at the enrollment, the increases, or the enrollment across the U.S. You're seeing it increase closer to 50% in several states. In Florida, actually the highest percentage, around 49% Medicare Advantage enrollees. You're seeing in other states close to 45, 40 in the 40. So again, the projection is even in some of these states, if you look at this, if you're in this state, if it's going to go up to 51% in total, we're talking some of these states, you may be 70 to 80% of your Medicare volume is now enrolled in Medicare Advantage from a billing perspective. So again, this is something to really keep your eye on. It's increasing at a very rapid and fast rate, and the data shows that you're continuing to see that movement across the country, especially even too if you look at some of the regions, you're probably seeing an increase at a higher rate than others. I know, when you're down in Florida, it's increasing at a rapid rate. In Florida, we've seen it increase a lot, and around the Northeast, but also out west, California, on the West Coast, and other states out there as well. So outside of that, right, that's talking home health more, and on that is also Medicare Advantage is also coming into the hospice market. So for those of you in hospice, we want to make sure that you do know that, and you are aware of the Medicare Advantage carve out, the value-based insurance design model demonstration. That was initiated January 1st of 2021. The demonstration does go through 2024. Plans must offer access to both in-network and out-of-network providers for 2021 and 2022. We've also seen a growth in the participants in this model. I believe in year one, it was somewhere around 40 or 50 plans. Now we're up to over 100 plans that are part of this model. The model includes wellness and healthcare planning, includes advanced care planning, Part C and D incentives, and reduced cost sharing programs, and the hospice benefit component, which is significant to many of your agencies that provide hospice that may have entered into some of these demonstrations with payer plans, or after 2024, you're going to have to be set up to be able to do that. The notice of elections and claims must be submitted to both Medicare and Medicare Advantage plans. That's what we're seeing right now. And the potential future implementation of 5-day timely filing for NOEs and notice of termination revocations as well. So again, we're seeing it in the hospice area. This is going to be significant for your organizations. Obviously, hospice has been predominantly about 99%, traditional Medicare. With Medicare Advantage and hospice, you're going to have to increase additional processes around verification of benefits, authorization, things of that nature that the Medicare Advantage plans may require. Plus, if they're requiring the NOEs, again, that process of submitting an NOE to a Medicare Advantage plan, how does that going to look and feel compared to how it is in Medicare? Making sure that they're set up properly, that you have the way to send them that information in a timely manner is going to be significant. So from a hospice perspective, If you have a home health, I think it's an advantage. You can leverage some of the knowledge that you have there, those processes around the non-traditional Medicare. But if you are a hospice that doesn't have home health, this is something I think you really want to look and plan for in the future. Start looking at what this model means. Also, even with the Medicare Advantage demonstration, the hospice benefit components, there are different services that are offered in the Medicare Advantage plans. We're finding that they're offering different things. They're making other services available to hospice patients, reimbursing for them. Something you want to take a look at as you go through this process. And then lastly, typically kind of what we're seeing from this model today is it being a percentage of the daily rate. So whatever your daily rate is, Medicare Advantage is offering, and usually the plan is offering a percentage. So it could be 80, 90% of the Medicare rate for those services. So keep that in mind as you start to do your financial planning. Is potentially the Medicare Advantage rates could be less than what you're receiving today from a traditional Medicare standpoint, because we are seeing only a percentage of the total payment, not the total in some cases. And then there's about 14 states that are participating, I believe now in year 2, and then, 23 states that are participating now in year 2, 14 participating in year 1, and a total of 116 participating plans. Again, this was more probably closer to, I believe, 35 or 40 or so in year 1. So we're seeing an increase in the number of plans that are offering this, both seeing it on the national level, some of the national plans, as well as some of the regional and local plans as well. That are offering this. I do think this is going to be a very big challenge for a lot of hospice organizations, because it's going to force us to change some of our workflows or processes, maybe even some of our staffing of our back office. And also it's going to affect us, our financial reimbursement, if we're not receiving the full hospice benefit rate that you are receiving from traditional Medicare. So now we're going to get to my favorite part, which some people's least favorite parts are, but I do find contracting to be actually a very a great conversation to have. And contracting can be a very labor-intensive process to reach out to these plans and negotiate what this is going to look like. First and foremost, when you're going into any kind of contract and you're looking at which plans you want, specifically which Medicare Advantage plans you are going to contract and negotiate terms with, is look at which plans make up a lot of your patients, right? So what we don't want to do is spend time in negotiating contracts with patients where there's only 1 or 2 that we get referrals from. If it makes up a big payer in our region, we want to focus on that. Typically, when I've gone as an interim CFO, I always go back to my intake department and ask them, okay, which payers have we had to turn down? Which payers are we not accepting? Which payers do I need to go back and get these potential contracts with from a negotiation standpoint? And who should we be in network with on that? So typically, I like to collect that data. So that's why, even from a standpoint of collection of information, the contracting process becomes so important. So what does that mean? When you're collecting the referral data, if you're not in network, or you don't have or you don't have a contract with that particular payer and you can't provide services, my recommendation is still document it as a referral, not taken under care because the patient was under this insurance policy. And that helps from a standpoint of bringing that information to your finance department, your CFO, or whomever is negotiating the contracts. Go and say, here's what we're turning down. Here's the potential business we had, right? I always call it the low-hanging fruit of your organization, right? Everyone wants to grow, right? We want to have our sales and marketing team go out there and get 10 more referrals, 10 more admissions. But what about that low-hanging fruit of that stuff that was just coming in the door that we could have potentially gotten, right? That all we had to do was be in contract, and we could have gotten that volume of payers. So as you go through the process, especially, I think it's important to capture this information, because what we don't want to do is, and I found this frustrating as a CFO, is when people have always asked me, go contract and negotiate with everyone, because I really want to focus on where our core business is, who are going to be the payers that are going to provide most of our volume, and who are the ones we can develop more relationships with based on just what we're currently getting referred from our referral sources. So keep that in mind, as you go through the process of contracting, is that collection of information becomes absolutely critical. So first and foremost, one of the things looking at is how do you get paid in Medicare Advantage? And we've seen a bunch of different ways. Typically, Medicare in the contract says, well, we follow Medicare guidelines. Doesn't necessarily mean they follow Medicare guidelines in terms of how they're going to pay you. For example, we see episodic payments. Some payers, not as many, are still on PPS, probably a small volume of them. Most of those that are episodic have converted to the Pdgm payment model on that. So you see a lot of payers now paying Medicare Advantage, paying the Pdgm. While some are doing that, some are still paying on a fee-for-service type model. So again, that's where you're probably going to go back and have to negotiate a rate, maybe $100, $120, whatever it may be per visit. So that's where the negotiation really happens in a lot of those contracts is what is our rates going to be? The third option that we're seeing more and more is going a value-based risk contracts using Pdgm rates. So we're seeing a lot of the Medicare Advantage plans say, hey, VBP is coming out soon, right? And people are going at risk for Medicare payments or getting increases by achieving certain objectives. So Medicare Advantage plans are seeing that similar model, and they're exploring it. And the Medicare Advantage plans have the data, they have the hospitalization rates, they can look at the patient satisfaction scores, timeliness of care, and they also have objectives. There's certain patient populations that they need to, they're reimbursed additional funding for based on the fact that they meet those quality objectives. So it's an opportunity now, I think, to kind of think outside of the box that maybe we can look at going at risk for some of these contracts or value-based, where we're getting a Pdgm rate or a percentage of Pdgm rate, and then we're incentivized to do other things. So if it's lowering hospitalization rate, that be something. If we're lower than, let's say, 15%, every quarter we would get a true up of a payment for that. There's a significant opportunity. One of the things I say is this is something I would explore specifically with some of your plans, but bring the data to the table, bring the information to show, hey, I have a lower hospitalization rate than my market. I have higher patient satisfaction scores. My timeliness of care is better than those others in my market, because what they'll do is Medicare Advantage plans are going to probably, just like Medicare is, right, look to say, okay, who do we want to work with? And the value-based purchasing model is really meant to say, okay, who are the providers providing the best care, and those are the ones we want our patients to be. Medicare Advantage plans are thinking the same thing, right? So we're going to narrow the network of the people we are contracted with, because we want to make sure that those that we're contracted with are providing great care, which is a good opportunity for you to kind of go at risk in some aspects of this. So again, just something to look at. We've seen it work, and we're seeing it grow more and more, and the openness to it. One of the things I strongly encourage as you go through that process is look and find out what are their challenges. What are the areas that the payer is potentially looking to improve? So there's a particular diagnosis, clinical groupings, that their hospitalization rate is higher and it's costing the payer more, and they're looking to leverage home care to potentially, reduce some of the risk there. So reduce the risk of hospitalization, prevent hospitalization. Have those conversations with the payers. I think it's really important. They're more open to it than they have been in the past. We've been working with a lot of clients, and they've been very, the payers have been more open to it in the past. I would say 6 years ago, if I ever mentioned that to a payer, they would have probably hung up the phone on me, or would have said, I don't even know what you're talking about. But the world's changing, so definitely it's exciting because we want to tie in that care we provide with the reimbursement we get. The last one is we've seen an increase in potentially using some looper rates for the fee-for-service rates. Again, while people say, oh no, they're looper rates, they still are better in a lot of cases than the contracted rates we see out there. A looper rate most likely gets you to a break even with a slight profitability, while typically some of the fee-for-service rates that we see out there right now in Medicare Advantage plans are well below the cost. Some not even aligning with the direct cost of the services provided. So those are some of the things just from a payment perspective to take a look at. As for the Medicare requirements, they always say, and I'm sure Lynn's seen many of these contracts, they say, we follow the Medicare requirements. Well, which ones and how do you follow them? Right?
Yeah.
That's a question you always have to ask, right, Lynn?
Absolutely.
So
not always the same. No.
The Medicare requirements are all the same. The Medicare Advantage requirements are not all the same.
Right. And I'll get into that a bit. It's quite frustrating.
But some of the things to look at, I mean, obviously the Oasis submissions, because most of them do require a HIPS code. So you have to submit some type of Oasis to get a HIPS code. So that's something to look at. Some of them do notice of admission. Some of them do no pay wrap. Some of them do different things. So it's making sure that their interpretation of Medicare, of what Medicare does, is the same as what your interpretation is, because as we talk about later, you have to set up your EMR to be able to do this, right? And what you don't want to do is get a bunch of denials and have to go back and say, oh, we had, the issues with the contracting, and our interpretation. Give you an example. I was working with an agency that entered into a Medicare contract. They interpreted it as being paid in a Pdgm format, because that's what Medicare's guideline was. The payer hadn't really converted over to Pdgm, but said in the contract. So what they were doing is they were billing at PD. They set up the payer as a Pdgm payer, got a bunch of denials, had to go back, look at it, and rebill as a PPS payer. So again, those are some things that just happen when you're working with the payer, that you have to make sure you clarify those requirements. It's not as simple as easy. Even I have one, for example, is one payer is the Oasis submission requirement, right? Their interpretation of an Oasis being submitted in 5 days, right? We have to do it because it's the best thing to do, but Medicare is not necessarily going to penalize us for not submitting in 5 days. Well, some payers say, well, we should penalize you for not submitting in 5 days. So in clarification of the Medicare rules in the contracting process is so important as you go through it. So ask a lot of questions. Don't assume they know everything about home care's Medicare payment methodology. So with that too is most of these plans, because they are typically managed care plans that have a Medicare Advantage, or managed care payers that have a Medicare Advantage plan, they still require authorization. They still require initial authorization, ongoing authorization on there. So keep that in mind as you go through the process. Some of them are different. We've seen some that completely follow the Pdgm methodology, where you don't need to require authorization over that 30-day period. We see some where you still have to, you get paid in 30 days, but you still are required to do 6 days of 6 visits of authorizations, or a certain amount of days of care. So make sure you clarify that. Again, don't kind of assume that because they're following Medicare guidelines, you just submit the patient, you submit the Oasis, you bill every 30 days. There's still probably going to be, in most cases, some type of authorization component, even for those ones that are paid episodically. Obviously, for the fee-for-service ones, most of the fee-for-service ones do require some sort of authorization requirement on that. And also to talk through that, I think that's a key component, is if there's anything you can do with their authorization policy where you're not requesting it every 6 days, especially when you're paying it on a Pdgm basis, because it really doesn't hurt them necessarily if you do 8 visits or 6 visits, because they're still paying you the 30-day value. Have those discussions with them to see what you can do. If you can go to like a 30-day authorization period where, hey, every 30 days billing period, we need to get additional authorization from the payer. Then other contracting items, obviously you want to look at your timely filing, making sure you're looking at your timely filing requirements. Again, Medicare is 1 year. I see Medicare Advantage plans be 180 days. So it's again, don't assume that because it's a Medicare plan that they're going to use the same timely filing requirements.
Mm-hmm.
So again, making sure, Lynn, you see that all the time.
Yeah,
right?
and it even changes throughout the different plans. Some are 180, some are 90 days. So yeah, you need to be really careful and know that each plan has their own requirements. And you need, to your point, Rob, you have to be really careful, really specific as to what the requirements are for that particular plan. I love how you said, don't assume, that just because it's Medicare, they follow Medicare guidelines, it means they're going to follow them to the T. And you're right. That I think is the most challenging process when it comes to billing Medicare Advantages. They are just so different throughout the different plans.
Mm-hmm. Agreed. And I think that's even, you go through the process is ask, you can never ask enough questions. I mean, I think that's the key in this. And then making sure you have the right billing codes, how the HIP codes are going to be set up and on as well. As I mentioned, the authorization policy, the appeal process, and then, looking at the eligibility and other things of that nature. And what are some of the things that Medicare Advantage plans are looking for? Well, this stuff really matters to them, and the more and more I've worked with them, that they're really focusing on hospitalization rates, specifically focusing on the diagnosis that have hospital length of stays and are costly to the plan. So those long length of stay patients, how can we potentially move them to home care to be able to provide the services and avoid hospitalizations? Or those frequent flyers, what are those ones where we see high readmission rates that they'd like to avoid on that? So again, when you're having those discussions with them, bring some data, bring some information. Recently, we shared with a group that does contracting some information on readmission rates by diagnosis. They were able to take it back to the payer and specifically look at some of the diagnosis where they could really add value, and it helped them negotiate. It helped them say, "Hey, we take care of 200 of your patients. We take care of 500 of your patients. How much money do we save yet, right? We're doubling the number, and we can provide that benefit." Timely initiation of care, again, that just correlates with quality outcomes, right? We don't see those patients within the first 48 hours. Typically, that's where they're at risk and most likely be hospitalized. So, the plans are very aware of that. So again, that's something to look at. The new buzzword with VBP is preventable hospitalizations. So can we prevent those patients from going to the hospital to begin with? So more of the preventive care model. Basically, this hasn't been elaborated too much by Medicare, but I can tell you that payers are very, very intrigued by this when we brought this up to them, is that Medicare basically will look at some of those diagnoses where, hey, can Medicare provide, or can home health provide services to prevent the hospitalization from happening in the first place? So if it's a community referral coming from the physician, what are some of those high community referrals that are coming over that we could potentially, are higher risk at being hospitalized, that home care has shown historically the ability to keep those patients out of the hospital. And then the patient satisfaction, again, making sure the patients are happy with the services they provided, the CAP scores and everything that comes back to them, whether it's the family and the patients, and looking at some of that, and really kind of focus on all those together. Sometimes what I find is, your timely initiation of scores might be great, but your patient satisfaction isn't, because you're rushing to get the patient out there, but then, or the nurse out there, but then they're being seen by 5 or 6 different, nurses, which obviously no one wants to be seen by 5 or 6 different nurses over, a 30-day plan, right? The 30-day period. So I will pass this to Lynn to talk a little bit about revenue cycle processes.
Awesome. Well, thank you so much, Rob. And, just like Rob, I've been in this business for a while, about 17 years now. And I have also worked in all the different positions, from intake all the way to being an administrator for a pretty large home health agency. And I've seen the growth in Medicare Advantage. It's unbelievable. It's, just like Rob, I remember where the majority of agencies were at 90 or almost 100% Medicare. And now we're seeing that just flip on its head. Whenever I talk to agencies, they're giving me stats of their 50, 60% Medicare Advantages or other payers. So it's really interesting how the industry has evolved and how important payer diversification is, and for us to, stay in touch with all the different changes. So, understanding Medicare Advantage guidelines are really important, specifically from a billing process. I'm excited to be here at today's presentation and give you the steps, the nuances of billing Medicare Advantages, because it is quite different from traditional Medicare. Like, Rob was saying, just because a Medicare Advantage follows Medicare guidelines, it doesn't mean that you can just make any assumptions. You've got to research each payer and each payer requirements, because there are slight differences. So, if you want to get paid, it's important that you and your staff do understand those differences. And, again, excited for you to be here and know that that you're all learning and understanding those differences. So let's talk a little bit about the revenue cycle and what those steps are. It's very important for Medicare Advantages to understand that there are specific steps that you need to follow, which are here on this slide, in order to get paid from any really Medicare Advantage. And the process starts with eligibility. Eligibility is a critical first step in the process, and we'll get into each one of these components as we move forward through the presentation. But eligibility, ensuring that the patient is eligible for home health is step one. And then from there, we're going to move on to authorizations. And, some of the stats we've seen is anywhere, I think it's about 63% or even more of the Medicare Advantage plans require pre-authorizations. So like, Rob was saying, look into each plan's specifications. Some may not necessarily require authorizations, but I would venture to say that the majority of them do. At least that's what we're seeing out there in the industry. So be really careful about authorizations. We're going to talk more about authorizations as we move forward in the presentation, but it's a critical component in making sure that you get paid through a Medicare Advantage. Orders management, that's always a challenge for us in this industry. I'm sure Rob can tell you. That is, challenging in itself, and it's just part of doing business in home health. So we've got to stay up with our orders, and again, we'll talk a little bit more about this. Billing, the billing process is different for each payer. So know and understand what the requirements for that specific payer are, and reading your contracts is critical. All of the requirements are going to be in your contract. So understanding what those are, reading those, staff education, trickling down through the entire process is really important to ensure that you get paid. Collections, which, when we say collections, we talk about following up on claims. Because, billing is, I like to say, is the easy step in the process. Clicking a couple of buttons in the software, submitting the claim to the insurance, anybody can do that. I think the hardest part of our business is really the collections piece of it. Following up with the insurance companies, making sure that you're getting paid correctly, following up on those rejections is really important. Having a clear, defined process in your agency is really going to be the secret to success. And we'll give you some tips on that also moving forward. And I think to finalize that, revenue cycle process is the reporting piece. And we see a lot of agencies that do a really great job of, eligibility, authorizations, order management, billing, collections. But, when it comes to the reporting, that kind of like falls off, right? And I know Rob is probably smiling about this because reporting, we live and die, as SimiTree for our clients on reporting. We cannot stress how important the AR function is, the aging reports, and staying on top of those reports, making sure they're clean and accurate. That is the full visibility of your business and the cash flow. Really, I mean, reporting is critical. So we'll talk about that as we move through. So let's go on to the next slide.
I agree with Lynn 100% because if you don't know, you don't know what you don't know. If you're not looking at it, you don't know. So, we talk about assuming. You could assume we're doing great, but I'm not looking at the reports and all the ARs building up because, example, sometimes if we're just looking at cash could be like this, admissions are like this, but we're not bringing in the cash. So it's so critical for your organization to really look at the full picture of the reporting.
Yeah, and you're right. That disconnect is so important, and a lot of it sometimes we see, and we'll talk a little bit more about this moving forward, but not accurately, not staying on top of posting, for example. Just not being timely about entering information into the software, I think is one of the top issues I see with agencies. And so the data, it's like they say, junk in and junk out. The data that you're looking at in your reports just doesn't really make any sense compared to the admissions or the cash. So really that reporting feature is so important. Eligibility, it is so critical to understand that eligibility is one of the top reasons for claim rejections. I mean, that is something that you really need to be very careful with. And when I talk about, errors in eligibility or, issues with eligibilities, I mean either simply not performing the eligibilities at all, which we have seen some agencies do, or even more commonly, not really understanding what is on that eligibility, right? And really understanding whether you can admit a patient or not. We've seen agencies that run an eligibility, don't really look at it or understand what's on that eligibility, end up admitting a patient that they should have never admitted in the first place. And of course, and once the claim is billed, it ends up getting rejected. And again, it all stemmed from an eligibility issue. So eligibility is really, really important in this process. And it's the first step in admitting a Medicare Advantage, any patient really, not just Medicare Advantage, but very, very important when it comes to Medicare Advantage. You must perform an eligibility before the patient is admitted. I know this sounds obvious, but I don't know what it is that we see some agencies that get really anxious, or some intake personnel, right, Rob? They get super anxious, really excited to staff a case. They want to make sure they quickly do their job, and they'll either not do the eligibility and just quickly staff it and send out a nurse. And subsequently, you find out that patient was really never eligible and you should have never admitted them to begin with. So, having some restraint in staffing that case and sending out and making sure you do that eligibility first is really important. Because obviously there's many circumstances that can cause a non-rejection of a claim. It could be, again, not doing the eligibility or not properly understanding the eligibility. Maybe the patient had a very high deductible that hasn't been met, and the patient is just not going to pay you in cash for those services. Whatever that may be, there's many different circumstances that can cause a patient not to be eligible, and for you to make a financial decision of maybe not accepting that patient. So just, be aware of that. Eligibility errors, like we said before, are one of the top reasons for claim rejections. In fact, we advise agencies to do eligibilities even in the middle of the month, not just in the beginning of the month. I know that Rob and I have had a bunch of conversations about that. And that gives you, doing the eligibility in the middle of the month gives you a little bit of time to make any kind of necessary operational changes. If the patient maybe is switching from one plan to another, or maybe even switching to traditional Medicare, and then, you've got to do an Oasis or whatever changes you need to do in the agency. It gives you a little time to, be proactive and be aware of that, and not just get surprised. Once you bill and you end up finding out that the patient changed insurance, and you've got to, make all these changes. And sometimes, again, you might not even get paid because it's too late. So doing those eligibilities before you admit the patient and at the middle of the month, I think is a really great step. All right, let's go on to the next slide.
And even too, big surprise, but like the payers don't update their websites like right the first day.
Yeah.
Like, even though I'm eligible and I change insurance plans, it's usually not even updated to like later on.
10 days maybe. Yeah, we've seen sometimes it takes 10 days for those eligibilities to switch over. Yeah. And then of course agencies will have a print screen of, their eligibility where it shows that the patient was on this particular plan or on Medicare Advantage or on traditional Medicare, and then suddenly 10 days into it, they're on an Advantage plan. It's really frustrating. And we've gotten, agencies that call us and tell us, well, what can we do about this? Well, I wish that we had a magic wand and we can fix some of these problems with the payers, but there really isn't much we can do other than, know that this happens, right? And do those eligibilities as frequently as possible, at least in the middle of the month. So you're, ahead of the game, really. So, we get a lot of, there's a lot of different questions on eligibility. Asking the insurance, it's important that there are specific questions that you understand that you have to ask the insurance company when you're doing an eligibility. Of course, whenever possible, you can try to do those eligibilities online through a web-based portal. But, we're going to go over in this slide the specific questions that you have to ask an insurance company, or at least look at in your documentation if you're doing it web-based, to ensure that you are able to actually admit this patient. Staff education is super important on this because, again, like Rob said, the different insurance companies have different requirements. Although they accept, they follow Medicare guidelines, still you're going to want to make sure that you're asking specific questions on eligibility and make your determinations at the agency level, whether you can take that patient or not. And, one of the basic questions is the patient eligible for home health services? I mean, it sounds pretty straightforward, but in my career, I've actually seen some insurances out there. They may not necessarily be Medicare Advantages, but I've seen some insurances out there that the patient doesn't necessarily have home health benefits. So that shouldn't really happen on a Medicare Advantage plan. They should have home health benefits, but it's important to ask and make sure that the patient is eligible for the services that you're going to be providing. Question number 2, insurance coverage, is it effective? It's unbelievable how many times a patient might give you a Blue Cross and Blue Shield card from 1988. And that card, is that patient doesn't even have that insurance, or the policy has been terminated. So be sure you ask, don't assume that just because the patient told you they have Blue Cross and Blue Shield, that plan is currently in effect. It's crazy how I've actually seen insurance companies give authorizations for patients, and I don't know if you've seen this, Rob, for patients that are not even on active service with them. It's insane, because clearly an authorization, and we'll talk about this as we go forward, is not a guarantee of payment. And I feel like insurance companies will give you an authorization for anything. They want you to see the patient, but do they really care if you get paid or not? I don't think so. They don't care if you get paid. They just want you to see the patient. So, watch out with that insurance coverage. Make sure that the patient has an effective policy. So another very important question to ask is, does the patient have in or out of network benefits? Now, when we talk about in or out of network benefits, we're talking about whether you're contracted or not with the payer. Now, with a lot of the Medicare Advantages, you may very well be able to see the patient, even if you're out of network, right? But it's really important to understand, ask that question, and then there's some subsequent questions you want to ask that we'll get into next, where you're going to make a decision whether you want to take the patient or not. So if you are in network, then, obviously you are in network, what your rates are, you'll be able to take the patient. If you're out of network, you're going to want to ask if the patient does have out-of-network plan. You may be able to take them. You just have to watch out for certain things like deductibles and copayments and some financial aspects that we'll talk about now. Authorizations. So pre-authorizations, I know that Rob touched a bit on this. Super, super important. I would say the majority of MA plans, Medicare Advantage plans, require authorizations. So you're going to want to ask that question. Does this patient's plan require authorizations? If so, you're going to want to get transferred to the authorizations department so you can get the appropriate authorizations to ensure payment. If the plan says that there are no authorizations required, then that's fantastic. Makes your life a little easier. Make sure you document that. Make sure you document a reference number of who you spoke to, the name of the person you spoke to, because, that's important. We have seen at times where agents at insurance companies sometimes give you the wrong information. So you're going to want to make sure you've got those reference numbers and the individual's names so you can subsequently appeal those claims if you need to, if you've gotten wrong information. Deductibles. So deductibles are critical. When it comes to Medicare Advantage plans, there are patients that have deductibles. You need to know if the deductibles have been met, and just know that whatever portion of the deductible has not been met is going to come out of your claim. So you've got to make sure that you are letting the patient know what their financial responsibilities are going to be. It's got to be documented in their consent forms so they know what portion of that deductible they need to pay you. So, if we've got agencies that sometimes don't ask that question about deductibles, then, later on when they bill the claim, they end up getting non-payment of the claim. And it's because they end up, let's say you have a particular patient with a $5,000 deductible that hasn't been met, maybe because you're an out-of-network provider and the agency had no idea, and then they try to collect the deductible later on, but the agency never informed the patient. The patient would have maybe not gone with your services and gone with a network provider. if they would have known they had to pay in cash for or pay their deductible portion. So, it makes it really tricky. It makes it hard for you to collect on payment for that particular claim. So it's very, very important to ask all of these questions when you are doing an eligibility. Know what the financial responsibilities are going to be for the patient. You need to know, and the patient needs to know what their financial responsibilities are, and it's got to be documented. Ask if there's any co-payments, max out of payment, out of pockets. All of that is important to know, what the patient's financial responsibility is going to be, what portion of those claims do they have to pay until the point where the insurance kicks in. So that's super, super critical. We've seen this as an issue with a lot of agencies. All right, let's go on to the next slide. All right, so let's talk about the different types of insurance and accepting insurance. It's a complex process. Like Rob was saying earlier on, there's so many different plans. So many different requirements. Medicare Advantage plans are able to charge whatever they want, make up their own rules with certain things. So it's important to understand that, there are hundreds of different plans that the patient could have, and you want to know when you're doing the eligibility, what particular plan the patient is on. They could be on a PPO, an HMO, fee-for-service. You've got to understand that so you make the appropriate decisions at the agency from an operational standpoint in order to subsequently bill that claim correctly. So, know that Medicare Advantage plans are also known. So there's a bunch of different names for a Medicare Advantage plan. They could be known as Medicare HMOs, Medicare replacement plans, Medicare, Advantage plans. All that means the same thing. It essentially means that the patient has elected out of traditional Medicare and they have signed up with a Medicare Advantage or HMO or replacement plan with a company like Blue Cross and Blue Shield, Humana, Aetna. Those are the insurances that manage those Medicare Advantage plans. Now, like we were saying earlier, a Medicare Advantage plan, it could be an HMO, a PPO, a fee-for-service. All these plans are a bit slightly different. So you do want to know what particular plan the patient is under. Just know that if a patient has signed up for a Medicare Advantage plan, it means they are not on traditional Medicare. Okay, so that's really critical because we've got agencies that say, oh, Medicare Advantage, same thing as traditional Medicare, you bill Medicare. Well, no. Medicare Advantage means they signed up, they've waived their rights for traditional Medicare, and they've signed up with some kind of insurance company like Blue Cross or Humana or whatever, and that's who you're going to bill. So that's super, super important. Now, all Medicare Advantages, though, are mandated by CMS, where they do have to provide at least the same level of service, home care service that's covered by traditional Medicare. So that part of it is true, the same level of service. However, they do have different rules and different restrictions and different costs. So know that piece, though, of it is different. Now, there's some, exciting news that has come out recently from CMS that's going to be effective in January 1, 2023, which is that CMS, I think, finally has realized that Medicare Advantage patients sometimes have reduced access to care because of high costs, right? And high cost sharing, where there's high deductibles or high copays or whatever it may be. And it's really restricting the access to patients to receive home care where, some patients are opting out of home care services where they really need it because they don't want to pay a higher deductible or a higher copay. So I'm super excited that CMS has finally recognized that Medicare Advantages are doing that. And they're actually going to begin to enforce Medicare Advantages as of 2023 to share the same cost savings with patients, or cost sharing rather, with patients that traditional Medicare has. So that's super exciting. We're hoping that that's going to reduce some of the deductibles and the copays that patients have, especially with some of those services revolving around therapy. as Rob was saying, some patients, have a hard time getting therapy when it comes to Medicare Advantage plans, either because the reimbursement rate to providers is really low, or maybe the co-payments are really high for a patient. So I'm really excited to see that open up. All right. So, and again, one last thing I did want to say on the previous slide is that whenever possible, if you can get the copy of the patient's insurance card, that would be fantastic. It's not always that simple to get that card, but it really makes eligibility easier, because at the back of the card, there's usually a phone number where you can do a direct phone call to that plan and get eligibility for the patient. Otherwise, hopefully having a web-based tool in order to do eligibilities will kind of help facilitate the eligibility process. Otherwise, if you're just going online, looking for Blue Cross and Blue Shield as an example, calling a general number, you may be transferred to a bunch of different departments. It could take you 2 hours to do an eligibility. But sometimes it's unavoidable because you really don't have a copy of the patient's card. All right, so next slide. All right, so back to the accepting the insurance. So as we talked a little bit earlier, staff education is so important. Educating your staff on the differences between the payers, even educating your marketers on the specific plans covered under your contract or under a particular payer is really important. Lack of understanding of the different service lines, I find, is one of the challenges within agencies. There's so many different services available to patients and under these different benefit packages. So I'd say, when it comes to the eligibility, walking your staff through the verification process, in particular, your intake staff, is super important. It's very, very, very critical for your intake staff, all of your staff, to have this education on the nuances and the differences of Medicare Advantage and what that eligibility process looks like, because we just, we said that eligibility process is different than traditional Medicare, right? It's a traditional Medicare eligibility is a little bit more straightforward. Medicare Advantage eligibility is a little bit more challenging, again, because of the different payers, the different plans out there, the different payer requirements. So I'd say that your intake personnel is a critical person at the office. That's a critical role. This needs to be a very detailed person. And I mean, frankly, in my opinion, it really needs to be someone who cares. I've always been a believer that hiring for personality is so much more important, because everything else is teachable, right? You can teach someone the skill, but you really can't teach someone to care. I think Rob might agree with me on that. And that intake person is kind of like your first defense. It's the front line, and they are a critical staff member to make sure that things that all your processes are correct, from the beginning. So your intake personnel is usually responsible for verifying that eligibility. So that's why that education piece of it is so important, in particular for the intake staff. They are usually responsible for gathering all the supporting documentation for the referral. So they're usually involved in getting the face-to-face, H&Ps, history and physicals, discharge summaries, whatever supporting documentation that you need for medical necessity. Usually your intake staff is the one responsible for that. They're usually coordinating with the supervisors, case managers, DONs for patient admissions. They're sometimes as well entering patient information into the system. So many times they're the ones that are selecting the payer. And we're going to talk a little bit more about selecting the payer as we move forward, because that is an area where we see a lot of issues. Selecting the right payer for a particular patient sets everything in motion. If you select the wrong insurance company just by accident for a particular patient, you're going to end up with a claim rejection. So, that's a very important step in it that we'll talk a little bit more about in the next slides. But, your intake staff member wears a lot of hats. They could possibly even be doing the coordination of authorizations and even creating the schedule in the software for all of the visits. So, the intake department is really who sets the process in motion. Like I said before, it's the first step. It's the first line of defense. If this step is not properly performed, then, and that error that was made upon intake could really trickle down through the entire process, resulting many times in claim rejections. So, like we said before, the payer setup portion of it is super important, and specifically selecting the correct payer, the correct insurance company in the software for a particular patient is very important. And intake is usually responsible for that. I would say that about in my experience, maybe 60%, and I almost want to say even more than that, of claim errors that we see stem from incorrect payer setups, whether it's the setup in the software or the intake personnel selecting the wrong payer for the patient. I mean, it's quite a bit, it's quite a high percentage, and it's really so simple, right? It's just such a simple correction, but a lot of it has to do with just understanding understanding the process. So, all right, let's get into the next slide. All right, authorizations, my God. So eligibility and authorizations are the biggest pain. These are our pain points. Authorizations, I would say that, like we said before, a lot of the authorization, the MA plans are requiring authorizations. At least 60 or more percent of them require authorizations. And I would say that authorization errors are one of the top rejections right alongside with eligibility problems. Those are the ones that we see the most out there. So, pre-authorizations can be issued by the insurance company in a few different ways. And again, it varies by payer. Some payers or some plans would would set up an authorization as a per visit authorization, right? That's a little bit more straightforward. Some of them could set up authorizations for the number of visits that you're going to be providing. And we've even seen some authorizations being set up by a time frame, right? Just maybe even any discipline by a certain time frame, or a specific discipline for a certain time frame. So it's important to understand what type of authorization you're getting, not just getting the authorizations, but understanding what type of authorization, just to make sure you're following those correctly. Now, ensuring the type of authorizations, the disciplines that are covered are super important, because, if you're going to be getting authorizations for HHA visits or nursing visits, whatever it is, you want to make sure you're getting the appropriate authorizations for the appropriate discipline, and understand that each one of those disciplines may very well have their own authorizations. So, typically we're seeing that agencies are calling the authorizations department at the insurance companies to obtain these authorizations, or there might be a portal to obtain the authorizations. I've seen where you need to fax documentation to insurance companies in order to get authorization. So the process of authorization varies depending on the insurance company. So, I think, like Rob said, upon contracting, understand what these nuances are, what are their requirements. You'll usually see that in the contracts, and make sure your staff is educated on what that process is. Typically, the insurance companies are going to provide an authorization number. Make sure, and this is a very important point, make sure that you enter those authorization numbers in your software, because they have to be reported on the claim in order for us to bill and be paid accurately. So please make sure that you don't just get that authorization number and put it on a sticky note and just stick it on your computer. I've seen that before. That's not enough. That authorization number has to be entered into your software. So so the purpose of that is for it to subsequently drop on the claim for us to be able to bill. So agencies should use software authorizations as well for their reporting system. So when you enter those authorizations into your software, you will have reports. So following up on expired authorizations is super important. A tickler system that is usually incorporated as part of your EMR will alert you of expiring authorizations or maybe no authorizations. That is very important. You need to have some controls in place to track the number of visits provided compared to the number of visits authorized. That I think is a pain point for some agencies. Providing visits in excess of your authorizations. What do you think that's gonna cause? That's gonna cause a rejection. That's gonna cause denials. Any visits provided without authorizations will not be paid. And we've come into agencies that have had so many problems with authorizations where their nursing staff actually does their own scheduling and just schedules themselves, on the calendars, and they go out, see the patients, but then there's no authorizations. And a lot of it has to do with lack of knowledge, right? Your nurse out on the field, your clinician, they just want to take care of the patient, right? They want to provide the services that are necessary. But just because you have a doctor's order or just because the service is necessary as per your clinician doesn't necessarily mean that you have an authorization from the insurance company. So, the clinicians need to understand that. And a recipe for disaster is having the clinicians schedule themselves. So it's important that you have someone with knowledge of this process in the office, creating those schedules, and they're the ones sending out, assigning the visits and scheduling the clinicians to go out and see the patients and ensuring that there are authorizations before a clinician does go out. Remember, clinicians want to, a lot of them get paid per visit if you're doing, contract. So you've got to make sure that you've got a clear process in the agency for scheduling visits, so you don't run into that no authorization or excess, doing visits in excess of authorizations problem. And like we said before, know that just because you get an authorization, it does not mean that's a guarantee of payment. It even says that sometimes in authorization documents when they fax them to you, it'll say this is not a guarantee of payment. I've got a lot of agencies that have said, well, wait a minute, I didn't get paid, for this claim, but I got authorizations. They have to pay me. Well, the answer to that is no, they don't. An authorization is not a guarantee of payment. Like I said before, I've seen insurance companies, it's unbelievable, but I've seen insurance companies provide authorizations for patients that are no longer on service with them or don't have an effective policy. It's crazy, but again, authorizations are provided liberally. Sometimes, it depends on the insurance company. Some of them have a hard time issuing authorizations, but some will give you those authorizations and not really care if you get paid or not. So watch out for that. All right, next slide.
Hey, Lynn.
Orders. Yes.
I'm sorry to interrupt you. I just want to let everybody know we are at the top of the hour. So if you do need to drop off, we are going to continue recording this. We'll be able to send it out to you. But if you want to hang out with us, we've got a lot of good information still to share.
Thank you, Missy. I know that, MA conversation, we can do this for hours. It's pretty intense. So thank you for everyone that wants to stick with us. It's really valuable information and a conversation that we have, I know, on the consulting and the billing side all day long with agencies. So orders. This is one of the most challenging, I'd say, and frustrating aspects of our business. Chasing after referring practitioners to sign orders is just one of those things we have to do. So, timely signed orders are critical for cash flow. We all know that we can't bill without having orders signed. So chasing after those orders and having a clear, specific process in the agency is really important. Assigning a specific person to track orders is best practice, ensuring that those orders are followed up timely and resubmitted if necessary. That's really the key. Not having a specific person responsible for tracking orders, I say, causes a lot of problems at the agency level. Use your software tools. Your software's got a lot of great reports, not just for authorizations, but for order tracking. Use those tools in order to know what orders are outstanding, set a frequency of when you're pulling those reports, and have that specific assigned person track those orders. Another key component of this is understanding each referring practitioner's specific requirements for getting orders back timely. There are some physicians out there that want to use an online portal. There's some that, that may want you to send the orders on a specific day to a specific person by fax, whatever it is. Know what those specifications are, because that's just going to help you get those orders in much faster. So having a process in place is important. And, on this slide we gave you, and this of course is just an example of what you can use as a process for tracking orders and staying on top of orders. We find that this is pretty standard and has been adopted by a lot of our agencies and works. On day 7 from start of care, you're going to send the orders to the physician's office. And again, this is just best practice. These times can vary upon agencies, but having a process in place regardless is important. Day 10, let's say you're going to call the physician's office to follow up on those orders. By day 14 or even sooner, you're going to call the office and speak maybe to a manager or whoever is specifically responsible for getting those orders signed. And you can ask that when you're calling the physician's office. Sometimes there is one specific person responsible for getting all those orders out. So you're going to want to reach out to them at least around day 14. And around day 20, if you haven't gotten those orders back, send a liaison, send your marketer, send the administrator, the owner, whatever it is, to go out to the physician's office and get those orders signed. That usually makes the difference if there's a physician that hasn't signed those orders. And typically you're going to know what are the frequent flyers or the difficult physicians, let's say, that generally tend to have a problem getting those orders signed. Hopefully it's not the majority of your physicians, but after a while you'll know who those are, and just maybe you might want to change this system in this process for those physicians. You might want to send a liaison a little sooner to those physicians if you know that they generally have delays in signing those orders. All right, let's go on to the next slide. All right, so let's get a little bit into the billing requirements. And I know that Rob touched based a little bit on this, but we'll talk a little more about it. It's important to understand that Medicare HMOs are different than traditional Medicare. We've said this throughout the whole presentation, and we cannot stress that enough. There's going to be different requirements, different ways that you need to bill them. So every individual plan has its own requirements. So have your billing manager read and understand the specific billing requirements for each payer. I mean, us, SimiTree, the revenue cycle department, RCM department, we've got a matrix that I like to say is from here to California. It's an Excel spreadsheet that goes on infinite. And it's just has all of the different nuances and specifications of all the different insurance plans. And we have to stay on top of that because insurance plans change. It's crazy how they will in midstream change a requirement and not notify any of the providers. There won't be a memo, there won't be a press release, there's not an email. You just sometimes find this out when you bill a claim and it gets rejected. So we constantly have to stay on top of this matrix and ensure that we understand what the payer rules are for each insurance company so we can bill successfully and so you can get paid successfully. So that's a really important part of our job and should be top of mind for your billers as well. Medicare Advantage plans are typically, like we said before, going to follow Medicare guidelines. But again, you need to know what their specific guidelines are, because some will require a face-to-face, some will not. Now, from a best practice perspective, we like to advise our agencies to just do face-to-face for all the Medicare Advantage plans, just to be covered on that, because they are a Medicare Advantage plan. They're supposed to follow Medicare guidelines, so you most likely are going to want to do those face-to-faces. Pdgm, like Rob says, some smaller payer, smaller percentage might still be in the PPS process, but the majority of them have transitioned to Pdgm. Then you're going to want to know whether you're going to be billing that payer episodically or per visit. And a lot of that is going to depend on how you're contracted with that payer. Are you going to be billing weekly versus billing monthly? Again, some of that depends on how you're contracted. Are you going to be billing an NOA, or are you still going to be billing the reps? You know, thankfully, we've seen a lot of the Medicare Advantage plans following Medicare Advantages and following the NOA process. You know, thankfully, there's a few stragglers there still on reps, but the majority of them are, we do need to submit an NOA, a notice of admission. So typically, I would say as a rule of thumb, and again, typically, you want to verify these things with the specific payer, but if you're in network, you're going to be billing per visit, since you've agreed on a per visit rate in a contract, right? So that means you should be billing weekly for those payers. Otherwise, if you're not contracted with the payer, you may be billing episodically. Then that means you're going to be sending an NOA and a final claim at the end of the 30-day period. So, you know, again, this is going to vary between plans. We've spoken to some agencies where they accept lots of different insurance companies, MA plans, straight commercial plans, a bunch of different insurances. And these, you know, I had a conversation the other day with an agency that they felt that they rather, just out of from a safety perspective, they rather submit an NOA for every MA plan, even if it's per visit, even though they're not required to do so. They rather do that because they're just afraid that, well, this MA plan wants an NOA, this one doesn't, this one I'm contracted with as per visit, this one I'm out of network. You know, they just don't want to be making all those on the spot decisions. And even if their softwares are set up to either not generate an NOA or generate an NOA, a lot of them just feel, you know, we've had these conversations with a few agencies where they just want to send NOAs to everyone. And again, that's up to you all. You know, that's clearly up to the agency and your policies and procedures. But, you know, that just gives you an idea of how confusing all of these plans are. So, you know, best advice is read those contracts. They're going to indicate the specific requirements the insurance company is going to want for billing. You know, alongside the fee schedules are important to understand. On those fee schedules, you're going to see the rates that they're going to be paying you, the HIPS codes that you need to use. So, you know, all of that is going to be in your contract. So reading those are quite important. All right, next slide. Oasis Transmission. So this is a conversation that I have, I would say at least weekly with agencies. There is such a confusion about this, but to clear it up in this webinar, if you are billing a Medicare Advantage plan, if you're going to admit a patient on a Medicare Advantage plan, you must do an Oasis and you must transmit that Oasis to CMS. Okay, so that's a requirement. Very, very important that if it's an MA plan, you do need to do an Oasis and you have to transmit that Oasis. So I think the disconnect is a lot of agencies say, all right, I know I need to do an Oasis because I need a HIPS code, but a lot of them think, oh, it's an MA plan with Blue Cross. I don't need to transmit that Oasis to CMS. Well, that's actually incorrect. It's in the guidelines. You do have to transmit those Oasis. In fact, it's the same rules as traditional Medicare. If you do not you have to transmit at least 90% of your Oasis, otherwise there's a 2% penalty. So you've got to transmit those Oasis, even if it's a Medicare Advantage plan. I want to make sure I clear that up. Know what your HCPCS codes are going to be for the payers. Now, the good thing, and again, it varies, but typically we see that the Medicare Advantage plans we're usually billing with the G codes, the same G codes that we're billing for traditional Medicare. Again, usually. And of course, that's going to go along with the 15-minute increments, which equals 1 unit. Now, you're going to find this information in your contracts and in your fee schedules. You just want to verify that, what's the specific HCPC code that we're going to be billing? What are the units that we're going to be billing? Again, usually it's going to be those 15-minute increment units. Timely filing. I know Rob touched on this a bit. So the traditional Medicare is a year to bill a claim. A lot of the Medicaid plans are a year. Timely filing when it comes to the Medicare Advantages varies. We've seen it to be as little as 90 days. We've seen it to be 180 days. One of the key components, and if you are going to create a matrix for the payer, or what are the payer rules for that specific payer, make sure that timely filing is one of the key components on there. Know when it's too late to bill the claim. So you've got maybe 90 days, maybe 180 days from admission to be able to submit that claim for payment. If you submit the claim, later than the timely filing, then what does that mean? It usually means that you're not going to get paid. Now, you can try and ask for some kind of exception, or ask, for them to waive the timely filing and allow the acceptance of that claim. We've tried. Sometimes it does. We've been successful with some agencies, but it's not always it's up to the insurance company. They may not waive the timely filing deadline. If you're going to try to do that, I would say that combine that phone call with the insurance company with a lot of begging and crying. I think that may work, but it doesn't always work. But because again, it's up to the insurance company if they want to waive that. Claim payment time frame. So depending on the payer, there are different time frames in which you're going to be paid, right? So I would say that they vary depending on the insurance company, anywhere between 30 to 90 days. I'd say, a lot of the large insurance companies like Blue Cross, Aetna, whatever it is, they're usually on a 30-day time frame, unless you start dealing with a Medicare Advantage plan that may be managed by a third-party payer, or third-party administrator, rather. If you're dealing with that kind of thing, then it could take a little bit longer to pay. It's just going to depend on that insurance company. All right, let's go on to the next slide. Payer setups. Gosh, like I said, payer setups are approximately, I'd say 60% or more of claim errors stem directly from payer setup issues. So what is a payer setup? So a payer setup has to do with getting your contract from the insurance company and adding all of the payer rules in that software, so you can end up billing an accurate claim. So if a particular Medicare Advantage, they're going to want you to use a HIPS code, they're going to want you to use 15-minute increment units, particular HCPC codes, whatever that is, you're going to add all of those rules into your software in order to generate a correct claim. Okay, so like I said, this is one of the first steps when you get a new insurance company. You're usually taking that contract, reading what the rules are, and entering that payer information into the system so you can generate an accurate claim. Getting this payer setup correct is a critical first step in the process. And even with getting this payer setup portion of it correct, it's not always a guarantee of payment. There could be something else that's wrong with the claim, like an authorization issue or something. But getting the payer setup correct is going to solve possibly 60% of the payer rejection issues that we see, at least. Now, a couple of tips on this. I don't recommend that your software company set up these payers for you. I know some may do that. Make sure that you have an experienced billing company like ours doing the payer setup for you, because payer setups are unique to each insurance company. They're specific for billing, and the softwares sometimes will add those for you automatically, but softwares are software. They're not necessarily billing experts, so be careful with that. Usually, if you contract with a billing service like ours, for example, we get a copy of your payer contracts and we add all those payer setups for you in your software, because we want to ensure that those claims are created accurately and correctly so you can get paid correctly and we can reduce any errors. So payer setups are really, really critical step in the process. All right, let's go on to the next one. Okay, so the next component of that initial slide that we talked about is collections. And like I said before, billing has its challenges, but I think collections is probably one of the hardest steps in the revenue cycle process. Without a timely follow-up process, you're going to end up with cash flow issues and reimbursement issues. So you've got to make sure that you're following up with the claims that you're billing timely, educating your staff on the different payer processing times and payer differences is very important. Following up with submitted claims within 1 or 2 weeks, I think, is a general rule of thumb, but it does depend, of course, on the payer. If you've got a payer that's paying you in about 30 days or so, 1 or 2 weeks is great for a follow-up on those claims that you've submitted. If it's a payer that's paying you in a little longer of a time frame, you might want to opt for the 2-week follow-up process, because if you follow up too early, if you bill a claim and you follow up the next day, sometimes the payers haven't even gotten the claim in their system. So you might just be making a very long and complex phone call that takes hours in order to just find out that the claim's not in their system yet. So you might want to give it a little time before you follow up with that billed claim. But that's a good practice, following up with the insurance company at a certain time frame after you bill particular claims. And you can do that by calling the insurance company on the phone. Now, some insurance companies do have a portal, or even through your clearinghouse and your EMR, you might be able to follow up on those submitted claims or rejection statuses or whatever it is. That's definitely a good practice. And, be prepared to spend hours on the phone with the insurance company following up on claims. Many times we'll get these rejections on our EOBs, and we'll talk a little bit about EOBs next, but we'll get rejections that are just boilerplate, definitions that really don't mean anything. A lot of times you have to call the insurance companies and figure out what really happened and why that claim is rejected. And I think, that's one of the hardest parts of all of this. And this is what really, us at SimiTree, this is what really we do best. We handle this entire process for you to ensure that you're going to be paid. We actually have an entire department with hundreds of people dedicated just to follow up on our clients' claims. It's really the stuff that gives me the biggest headache and gives agencies the biggest headaches. But we handle that portion for you to ensure that we're following up on claims and making sure that you're getting paid accurately, and any rejections or anything wrong with the claims, we're responsible for handling that. Okay, next slide. All right, so when it comes to insurance companies, MA plans, sometimes you will get correspondence in the mail, and that correspondence in the mail could be an explanation of benefits, an EOB, which is going to give you payment information. They'll tell you this particular check was, here's the specific patients that were paid on this particular check. You could have rejections on that EOB. You could have a letter stating that there was an error in that particular claim. So make sure that you're giving this information to your billing department or to your billing service. Make sure that they're looking at those paper rejections or any kind of correspondence from the insurance company, so your billers can follow up timely with that. Checks in the mail, sometimes you will get insurance companies that'll send you checks in the mail. So I would say one action item that I'd love to see everyone on this webinar do today is go back to your agencies and see what insurance companies you're getting paper checks for, and then just simply call the insurance companies, maybe call the enrollment departments and ask for an EFT form, which is an electronic funds transfer form. Fill that out, because that's not automatic. Every time you get contracted with the insurance company, you don't automatically get an EFT form along with that contract. Sometimes you have to ask for that separately. So if you're getting any paper checks, go back, find out who those insurance companies are, go back, it's a pretty simple process. Fill out an EFT form, and that alone is going to increase your cash flow, because you're going to get that deposit of that check anywhere between 48 to 72 hours into your bank account, whereas a paper check in snail mail could take you 3 weeks or more to get in the mail. So just with that action alone that you can do, today or tomorrow, you can increase your cash flow. So I highly recommend you go back to the agencies and do that today if you can. Now, when you do receive payment for a particular claim, make sure that you're being paid according to the contract. Many times we see underpayments in EOBs because maybe the units were billed incorrectly. So just be sure that you're checking your payments. Don't just assume, oh, this is what the insurance company paid me. This is what I'm getting. Just check those against your contracts. Make sure that you're being paid correctly. And patient responsibilities, of course, if there's any patient responsibilities on those EOBs, make sure that you've got a process in the office where you are billing, invoicing the patient for any responsibilities that, financial responsibilities that they have. All right, let's get into the next slide. All right, so we're almost done here. Thanks again for sticking with us. Last couple of last points here are denial management. Now, you can get denials, of course, for billing errors. You can get denials for authorizations, for eligibility issues. There's many different issues where a denial can pop up. Now, what's important here is how you manage that denial. Different insurance companies require you, their specific processes, let's say, on how to deal with claim rejections. Some insurance companies you can call, simply make a phone call and resubmit a claim, especially if it's like an authorization issue, maybe where you're getting a rejection for no auths and you do have an authorization. You may simply be able to call the insurance company and they would resubmit that claim for you over the phone. You may need to file that claim electronically, resubmit it. Just make sure that you understand if you have to file a corrected claim, if you have to file an appeal for that rejected claim, whatever that in particular insurance company's process is, important to know that, because if you just submit a claim, do a correction, submit it without really understanding if you have to do, for example, a corrected claim, you could end up with a second rejection for a duplicate claim. So be very careful and understand if you have to file a specific code for a corrected claim, what that requirement is for the insurance company so you can get that corrected claim in correctly. And of course, the time frame on that, obviously is as soon as possible, but at least 7 days after the denial, submitting that, I would say that's probably best practice. Know that there are some payers that may take you a little longer to figure out what the rejection is. And some of that has to do with long wait times, on hold with insurance companies. They limit the number of claims you can follow up on one single phone call. So, there might be some delay, not because of your lack of trying, but just because of the process and the timeliness of the insurance companies to get back to you on why something is rejected. So, that is going to vary, but 7 days after the denial, I think is a good number. All right, let's get on to the next slide. So let's talk about a few common rejections or denials that we see with insurance companies. One of them that we see a lot is claim not on file. So that sounds really straightforward. It sounds like, well, maybe you didn't file the claim. And that's why when you're following up with a claim that you thought you billed, you get a response from the insurance company rep that says the claim is not on file. Well, be careful with that because the claim could very well be not on file. It could be that the claim, you've got proof that from your software that you build it, maybe the person on the other line isn't looking in all of the different databases that they need to look at, and they might not be seeing your claim. So you might want to press the insurance rep a bit and ask them, hey, are you looking at all the databases? Because I do have proof here that it was submitted. So you might want to press them a bit. Now, claim not on file could be that you do have proof that you submitted it, but maybe you submitted it to the wrong insurance company. Maybe the patient is a United patient and you submitted it to Blue Cross and Blue Shield. So that happens. And that, that stems from maybe what we talked about earlier, the intake person not being mindful or careful about selecting the right payer for that particular insurance company. So we see this a lot. Be careful. It could very well be that you just selected the wrong insurance company in the demographics in your software for that particular patient. So be careful with that. Incorrect patient identifier information. So this usually has to do with wrong patient information, like date of births being incorrect, patient names being spelled incorrectly, policy numbers, wrong policy numbers. So anything that has to do with incorrect patient identifier information is usually demographical information that's incorrect. And those are typically typos, and we see that a lot, and it's super avoidable. So be really careful with your intake staff entering patient information. Make sure they're also entering patient information directly from the eligibilities from the insurance company. Make sure they're spelling the patient names the way the eligibilities are shown, and make sure that date of births are correct and all of that. No authorizations. So no authorizations, it could be that you don't have an authorization and the claim is being rejected. It could be that you get a no authorization, but you really do have an authorization. So you may want to call the insurance company and tell them that you do have an authorization. They verify that that information is accurate, and then they'll refile the claim. I mean, I wonder, that happens a lot. I wonder why. Sometimes, you know, I've been in this business for a long time. I'm a little bit jaded. Sometimes I think that insurance companies do it on purpose. I don't know if that's right, but sometimes I feel like they do it on purpose because I guess they're hoping that a majority or at least a big portion of agencies don't call, you know, to follow up on their payment. So I don't know. That's just my jaded take on this. But sometimes it's true. Sometimes you don't have an authorization, or sometimes it's a little more complex than that. Sometimes it's that you got an authorization for HHA visits, but you didn't get an authorization for skilled nursing visits, and what you billed was skilled nursing visits. So that's something that we see sometimes. So be really careful with your authorizations, not only making sure they're in the software so they drop on the claim, but making sure that you're getting the appropriate authorizations for each discipline that goes out to the home. That's a key component to that. Coverage termination and non-covered services. So a lot of that stems back to your intake person. It has to do with maybe an eligibility issue, like we talked about before. Maybe the patient never had home health services to begin with, or their policy was terminated and you admitted them anyway. So a lot of that has to do, any coverage termination, non-covered services, sometimes stem back from eligibility. Non-covered services could even be that you use the wrong HCPCS code altogether. And so, you know, that particular HCPCS code was incorrect. So you'll get this boilerplate rejection saying non-covered services. So you got to do a little digging. That's why sometimes you do have to call the insurance companies and spend that time on the phone and figure out what's really wrong. Missing or invalid CPT HCPCS codes, same thing. You know, wrong codes put on the claim. So you'll want to call the insurance company to clarify that. And timely filing issues also are a big one. And like we talked about before, know when it's too late to submit the claim. Make sure you're submitting them timely so you don't get an error of timely filing. All right, let's go on to my last slide. All right, so financial reports. We talked about how important this is. SimiTree, we live and die, you know, with financial reports, aging reports, AR reports for our clients. That is what we're looking at day in and day out. Keep a very close eye on your aging reports. So your aging reports are going to tell you basically what claims are outstanding and how old, what's the age of those claims. All of your softwares are going to have these AR aging reports. Now, know, like I said before, that, you know, they say junk in, junk out. If you're not staying on top of your posting, for example, if you're not posting your paid claims timely, then your aging reports could look crazy. I mean, we've had agencies call us saying, oh my God, we have $3 million worth of outstanding claims. And then when we start doing a little digging, we realize that, you know, the majority of them are not truly outstanding. They just haven't been posted. Okay, so you're not going to be able to run your agency successfully and know what's going on if you're not up to date with your posting. even adjustments are really important. We recommend having specific codes for bad debt, for example. So look, in this business, there are some claims that aren't going to get paid. All right. There are issues that happen, errors that happen, claims that aren't going to get paid. Try to stay on top of every month, making sure you write off or adjust out those claims with a specific code from your AR. So that way, first, you have accurate AR reports. Accurate. So, and when I say an accurate AR report, I mean a true report of what claims are truly outstanding. So that way, when your collections people are spinning their wheels and calling the insurance companies, you want to make sure that they're not wasting their time, their precious, valuable time, right? That you guys are paying a lot of money for. You want to make sure that they're spending their time on claims that they can actually possibly collect, right? You don't want them spending their time on figuring out, oh, that claim was paid. It just needs to be posted, right? So careful with that. Know that what I really like about adjusting with specific bad debt codes is you can later on run reports. Maybe your financial team can, or your billing team can run reports and figure out, hey, you know, these are common reasons for bad debt. And maybe it's eligibility issues. Maybe it's on authorization issues. And that is a really good tool to know where there's going to be some opportunity for education, right? So if you see that the majority of your write-offs or adjustments have to do with authorizations, hey, red flag, that's an opportunity where you need to train the people in your authorizations department and see, really dig a little deeper into that and see what's going on with authorizations so you can kind of improve your cash flow and improve that. So, you know, understanding your cash flow trends are really important. And just know really that any Medicare Advantage claim that is over 70 days, I would say, sitting in your AR unpaid is an issue, right? You know, go after them, call the insurance companies, figure out what's wrong with them. I think 70 days is a good mark to start following up. You do need to give a little time, you know, 30 days. If it's still outstanding in 30 days, you might want to give it a little time. But, you know, once you start hitting 70, you're going to want to start calling that insurance company, figuring out what's wrong with that particular claim. All right. Thank you so much. That concludes my piece of it.
And it just
Rob,
kind of,
I'll hand that over to you.
thanks, Lynn, and just kind of reiterate some of the areas, you know, with the payer setup. You know, we talked about rates, insurance information, authorizations, Oasis, but revenue recognition methodology, making sure your revenue methodology matches what the payer is paying. And then, like we said too, looking at those adjustments, because sometimes payers have different, they may give a percentage of Medicare, they may give a different loop concept, just making sure you're tracking that information on an ongoing basis. Perfect.
Awesome. Thank you so much.
Quite a few questions. So what I will do is pull the Q&A from both the chat and the Q&A, and I'll get that to Lynn and Rob and have them answer those questions. And we'll get those questions and answers emailed out to everybody since we are a bit over today. We really do appreciate the time and attention that everybody gave us today. I hope you enjoyed the presentation. If you need anything or have any questions, please don't hesitate to reach out. You can reach out to training@SimiTreeHC.com and we'd be happy to get you whatever you need. With that, Lynn and Rob, thank you so much for a wonderful presentation. Thank you all for attending today.
Thank you so much, everyone.